Good afternoon, everyone. It is my pleasure to welcome you all to the annual Kessler Enrichment Lecture. This lecture was developed by Kessler family in 2016 with the goal to fund education for our healthcare providers with focus on the chronic disease. And this is the 6th year. We have been so fortunate to have some expert enlighten us with their areas of expertise year after year. And this year will be no different. I'll be happy to introduce this year's speaker, Shah. She is an associate professor of medicine at Johns Hopkins University. She is a graduate of MIT, has done internal medicine residency from Stanford University. She has done rheumatology fellowship and Master of Health Science in clinical investigation at Johns Hopkins University. She serves in many leadership roles at Hopkins. She's Associate Division Director for Johns Hopkins Division of Rheumatology. She's Co-Director of Johns Hopkins Scleroderma Center. And she directs precision medicine initiatives through Johns Hopkins Individualized Health Initiatives. Her clinical expertise is in field of rheumatology, focuses on scleroderma and Raynaud's phenomena. Her research focuses on interface between cancer and autoimmunity in scleroderma and myositis, also in immune checkpoint inhibitor related adverse events. She also has an active research in other fields or other areas of clinical and therapeutic in scleroderma and Raynaud's phenomena. Her research contributions been recognized at national and international levels. She has won some prestigious awards at Systemic Sclerosis, World Congress, and American College of Rheumatology. We are thrilled to have you, Ami, with us. She is going to talk to us about immune checkpoint inhibitor related adverse events, mostly the rheumatologic adverse events. Welcome, Ami.
Wonderful. Thank you so much for that kind introduction and for the invitation to speak with your group. Just going to share my screen. Hope everybody can see this. So today I'll be speaking about rheumatologic consequences of immune checkpoint inhibitors. I don't have any relevant financial conflicts of interest to disclose, but I do receive some research grant funding for scleroderma clinical trials. And I will be discussing the off-label use of immunosuppressive therapies to treat immune-related adverse events. So my objectives today are to talk a little bit about the mechanism of action of immune checkpoint inhibitors and to discuss the spectrum of rheumatologic immune-related adverse events that can develop with cancer immunotherapy. I'll briefly talk about treatment approaches for rheumatic IRAEs, and if time permits, talk about the use of immune checkpoint inhibitors in patients who have pre-existing autoimmune rheumatic disease. So as we all know, the immune response is very carefully regulated in that activation pathways are balanced by the presence of naturally occurring inhibitory pathways. And the goal here is to enable our immune system to respond to pathogens of concern, but to dampen and control the immune response to prevent self-injury. The concept of activating the immune system to treat cancer has been one that has been of great interest for a long period of time. And this includes an early description of the use of colitoxin as a bacterial vaccine to treat a previously inoperable sarcoma. And then there was a major advance in the 1980s with the description of a 33-year-old woman who had metastatic melanoma and was treated with recombinant IL-2. With all evidence of her cancer being gone within a few months. And this was really a beautiful demonstration that a purely immunologic approach could be used to treat cancer. So to understand the mechanism of action of immune checkpoint inhibitors, we need to take a step back and review how T cells become activated. And as you may recall, T cells require at least 2 signals for activation. The first is when a T cell receptor recognizes peptide bound to MHC on a dendritic cell or other antigen presenting cell. But this signal alone is not enough for T cell activation. So we need a second co-stimulatory signal, and that's shown here with CD28 on the T cell binding CD80 or CD86 on an antigen presenting cell. And after the second signal is present, a T cell can become activated. But like most of our biological systems, there are checks and balances that are built in to prevent T cells from becoming overactivated. So once the T cell becomes activated, CTLA-4 is trafficked to the surface of the T cell and can interact with CD80 or CD86 on the antigen presenting cell. And this serves as a negative or inhibitory co-stimulatory interaction. There are also other pathways that can prevent T cell overactivation. And for the purposes of immune checkpoint inhibitors, an important one is PD-1 on the T cell interacting with PD-L1 or PD-L2 on target tissue. And similar to the CTLA-4 interaction, this binding of the receptor with its ligand can inhibit T cell activation. So these are the two main pathways that are inhibited by immune checkpoint inhibitors. There are now numerous immune checkpoint inhibitor agents that are available on the market, and you can see there's really been a rapid pace of drug approvals, starting with the first agent targeting CTLA-4, known as ipilimumab, in 2011. And as you can see, there is a wide array of tumor types for which these drugs are now indicated, and the list is rapidly growing, including first-line and adjuvant use in some situations. Combination therapy is also being trialed increasingly, including the use of combination ipilimumab and nivolumab. And we'll talk about how combination immune checkpoint inhibition can be particularly relevant for the development of immune-related adverse events. So the use of these agents has really been rapidly growing. This was an interesting study that was published in one of the JAMA Network journals, and they looked at the percentage of US patients with cancer who are eligible for immune checkpoint inhibitor therapy, and they estimated that the percent of patients who are eligible for immune checkpoint inhibitor treatment increased from 1.5% in 2011 to over 40% in 2018. And those estimated to respond to these drugs with respect to their cancer also increased from close to 0% to over 12%. So this is continuing to increase and become a major cancer therapeutic strategy. So the key question is, what happens when the forces of activation outweigh those of inhibition? And it's increasingly been recognized that these immune checkpoint inhibitors have tremendous potential as a cancer therapeutic, but to some degree, they are a double-edged sword. And that's been recognized in the lay press with articles in the New York Times, as well as key perspective pieces like this one shown here in Nature Medicine, where they ask the question, is autoimmunity the Achilles heel of cancer immunotherapy? So these immune checkpoint inhibitors can cause immune-related adverse events, and we refer to these as IRAEs. This is when there is unopposed general T cell activation that's inducing a robust immune response, and this can be beneficial from an anti-tumor perspective. But when there is off-target non-tumor tissue damage, this is when we're concerned about immune-related adverse events. These IRAEs can be disease and drug agnostic. They've been seen with all immune checkpoint inhibitors and across all tumor types. They may be more common and more severe when combination immunotherapeutic strategies are being employed. And there are some important differences that are emerging in terms of the types of immune-related adverse events that patients can experience depending upon the type of immunotherapeutic agent they're being treated with. We can see a diverse array of phenotypes, so there can be involvement of multiple organs and multiple organ systems when patients develop immune-related adverse events. And patients can often have more than one immune-related adverse event, and these can be multiple IRAEs happening at the same time or multiple IRAEs that occur in sequence. Their severity can range from mild to life-threatening. The timing of when these events emerge can be highly variable after the immune checkpoint inhibitor. So some of these events develop relatively early and others can develop quite late. Most of these are monophasic, but as I'll tell you in the rheumatologic spectrum, we are seeing that some of these have the potential to become chronic diseases that require longitudinal care and management. And at this point, we don't have well-defined risk factors for who's more likely to develop an immune-related adverse event or a specific type of immune-related adverse event compared to another. So this table just shows some of the commonly recognized immune-related adverse events, and I just wanted to provide a brief overview of them. So colitis can develop, and diarrhea has been reported in up to 30% of patients who are treated with immune checkpoint inhibitors. This can be severe in some patients and result in bowel perforation. There's been a wide variety of cutaneous manifestations that have been described after immune checkpoint inhibitor therapy, and these events tend to occur early and can occur in up to a third of patients. In terms of endocrine manifestations, thyroiditis and hypophysitis has been reported. Pneumonitis can also develop, and this can range from being fairly mild to quite severe, resulting in respiratory failure. There can be hepatitis, involvement of the central nervous system or peripheral nervous system, including development of myasthenia, which we'll talk about as that can be seen in overlap with myositis. And patients can rarely develop myocarditis, which can be quite severe and potentially fatal. So outside of those commonly recognized immune-related adverse events, there are a number of IRAEs that we as rheumatologists are starting to see, and that includes the development of inflammatory arthritis, myositis, scleroderma-like disease, sarcoidosis, vasculitis, Sikka syndrome, and polymyalgia rheumatica. And until relatively recently, these were not well recognized. So this is some educational material that was produced for oncology providers and for patients who are receiving immune checkpoint inhibitor therapy. And you'll see that they cover a number of immune-related adverse events, but what's missing here is the rheumatologic piece. So to begin to understand this, we had conducted a systematic review of the literature, including studies where PD-1, PD-L1, or CTLA-4 inhibitors were being administered, and where there was mention of a musculoskeletal or immune-related adverse event. We included data from 33 clinical trials at that point in time, case reports and case series, and observational studies. And one of the things that we learned from the clinical trial literature is that it was very challenging to understand the types of rheumatic immune-related adverse events that patients were experiencing, in part because some of the descriptions were somewhat vague. So you can see that arthralgia has been reported in 1 to 43% of patients, a very wide range, myalgia in 2 to 20%. There was mention of arthritis in 5 clinical trials, although there wasn't definition of the type of arthritis that patients were developing. There were reports of Sikka symptoms and isolated reports of other manifestations like vasculitis. In terms of case reports and case series, it became clearer that there were indeed cases of true inflammatory arthritis, myositis, vasculitis, polymyalgia rheumatica and giant cell arteritis, and lupus nephritis. And in observational studies where patients were getting followed with PET CT scans to look at cancer response, there has been description of arthritis that was incidentally noted on imaging. So our conclusion from this initial study is that musculoskeletal and rheumatic immune-related adverse events were poorly recognized or described in randomized control trials. And we thought this may be diluted by a lack of standardized reporting, because in a clinical trial, an event could be coded in many different ways, for instance, as a joint effusion or arthritis or arthralgia or a change in range of motion as an example. And in particular, the oncology CTCAE grading scheme that they use for clinical trials may undercall arthritis and autoimmune manifestations, because some of our manifestations are not life-threatening, like arthritis, and they rarely lead to hospitalization, and therefore they may be underreported. And we felt that there was an educational gap, although that is rapidly improving. So when we think about our rheumatic diseases, most, but not all of them, have a similar immune-related adverse event. And the literature on this continues to expand as more and more cases are published in the literature. And I've mentioned some of these manifestations thus far, but I just wanted to highlight that single organ vasculitis, ANCA-associated vasculitis, subacute cutaneous lupus, psoriasis, psoriatic arthritis, eosinophilic fasciitis, and even critical digital ischemia, like we can see in scleroderma patients, have all been reported to develop after immune checkpoint inhibitor therapy. So I wanted to walk you through a few representative cases just to give you a sense of the types of cases that are now coming to our rheumatology practice and what you may see in your practice. This was a 48-year-old woman who had stage 4 melanoma, and she had no prior history of autoimmune rheumatic disease. She was started on ipilimumab and nivolumab therapy for her melanoma, and she developed colitis that required treatment with corticosteroids. This improved with treatment, and she continued on nivolumab therapy, and then she developed hypophysitis and again required treatment with steroids. She was tapered from 60 milligrams of prednisone per day to hydrocortisone replacement therapy for persistent adrenal insufficiency. And after her prednisone was stopped, she described the onset of aching in her hips, knees, and shoulders after her nivolumab infusions. She completed her immunotherapy regimen, but her joint symptoms persisted. And then she developed swelling in her PIP joints and MCP joints of her hands. And she was referred to rheumatology 6 months after her immune checkpoint inhibitor therapy was stopped. So in the rheumatology clinic, she had evidence of synovitis in multiple PIPs, her wrists and her knees. She was serologically negative with respect to ANA, rheumatoid factor, CCP, and extractable nuclear antigens. And she was started on prednisone 40 milligrams daily with a taper and methotrexate 15 milligrams weekly. The methotrexate was up titrated, but she had an incomplete response and was having some adverse effects. So she was switched to a TNF inhibitor, adalimumab, with a good response. And her melanoma has remained in remission after 6 months of being on a TNF inhibitor. So I think this case illustrates the potential evolution of symptoms that a patient can experience. And when we've looked in our cohort, and as has been described by others, there really can be this heterogeneous pattern of joint involvement. So some patients may present with polyarthritis or an oligoarthritis, and that tends to be more common than the presentation of an isolated single joint that's involved. But in most instances, patients present with medium to large joint involvement first, and then they can evolve to develop a small joint polyarthritis. Rarely, we have seen classic reactive arthritis with conjunctivitis, urethritis, and arthritis. And in our experience, this has been exclusively in patients who are being treated with combination immune checkpoint inhibitor therapy targeting both CTLA-4 and PD-1. We've also seen tenosynovitis and other tendon involvement as well. In most of these patients, inflammatory markers are elevated, but interestingly, these patients are largely HLA-B27 negative and largely seronegative. So there have been some reports in the literature of patients having seropositive RA, and in some instances, patients having evidence of rheumatoid factor and CCP before exposure to the immune checkpoint inhibitor, but largely these patients are seronegative. They often have inflammatory joint fluid with neutrophil predominance. And on imaging with musculoskeletal ultrasound and other modalities, there's been evidence of effusions, synovitis, very rapid development of erosions, and tenosynovitis. We've studied this to look at whether or not the clinical features of immune-related adverse events differ between people who are getting PD-1 or PD-L1 monotherapy versus combination immunotherapy. And I just want to highlight a few things here in that patients who have combination immunotherapy treatment often present with large joint involvement and have elevated inflammatory markers and have had multiple immune-related adverse events. But we are seeing patients who have more of a rheumatoid arthritis-like presentation with small joint polyarthritis and inflammatory arthritis as the first immune-related adverse event, predominantly in patients who are treated with PD-1 or PD-L1 monotherapy. And while this study was an initial small pilot, as our sample size has grown over time, these findings have held. Now, in terms of when these events clinically emerge, they can be highly variable and much later than what has been seen with other immune-related adverse events. So this is data from a study looking at the time from immune checkpoint inhibitor initiation in terms of when an immune-related adverse event develops. And we can see that hypophysitis, colitis, pneumonitis tend to occur earlier. But inflammatory arthritis really can occur many months out from starting an immune checkpoint inhibitor, and this can be quite variable. We've also observed that there may be a delay in recognition of inflammatory arthritis in patients who are developing these symptoms. So here we looked at the time from when a patient developed symptoms of inflammatory arthritis to when they were diagnosed, and based off of their initial pattern of joint involvement. So patients who had involvement of a large joint presented relatively quickly to rheumatology for evaluation, but those who developed a small joint polyarthritis often had a significant delay in referral and recognition of the condition and treatment. So I just wanted to show you some images from some of these patients to give you a sense of what can be seen. This is an image from a patient who had Doppler positive tendinitis at the patellar tendon insertion. Another patient who had a patellar enthesophyte on the left on ultrasound and Doppler positive wrist tenosynovitis, as shown on the right. And on the left here, this is a really interesting case of a patient who had Doppler positive synovitis of the talonavicular joint. But what was striking about this case is that this patient very rapidly developed an erosion after just a few months of symptoms. So it can be quite impressive in terms of the severity and progression of disease that we can see in these patients. And on the right is an MRI image demonstrating tibiotalar synovitis. So when we think about treatment considerations and outcomes in these patients, we do think that there may be a delay in referral for inflammatory arthritis in patients who are developing this as an immune-related adverse event. And this is concerning because, again, these patients seem to have the potential for very aggressive disease and rapid development of erosions and irreversible damage. So we think that there's an important educational gap that is continuing to improve as both patients and providers have increased recognition that this can be an immune-related adverse event. Symptom control acutely is actually very important in these patients because they're often having to face complicated decision-making with their oncology providers about whether or not they can safely continue their immune checkpoint inhibitor therapy. We really need to work to better define treatment approaches for inflammatory arthritis because if patients can very rapidly develop erosive disease, it may be that our traditional step-up approaches that we use to treat diseases like rheumatoid arthritis could be problematic, and we may not achieve adequate and timely control of the disease. And importantly, I think we're increasingly recognizing that these patients may actually develop chronic disease and require chronic management. So this is somewhat different than the other immune-related adverse events that have been reported. So in terms of treatment, our approach has been for mild cases where a patient is presenting with monoarthritis, for instance, that we can treat with intra-articular steroids. But most patients do need the use of systemic corticosteroids, especially those who are being referred to rheumatology. And we have often required the use of disease-modifying anti-rheumatic therapy, including methotrexate, hydroxychloroquine, and leflunomide. And in many patients, we do have to go on and use TNF inhibitors. The use of tocilizumab has also been reported by other groups, including the MD Anderson Cancer Center Rheumatology group, as another potential therapeutic strategy. There is some debate as to whether or not it's safe to use these disease-modifying anti-rheumatic drugs in patients who have cancer. And thus far, we have not seen any worsening of tumor response in patients who are treated with DMARD therapy, but this is an area of active investigation. Interestingly, we are concerned about this persistence of inflammatory arthritis after immune checkpoint inhibitors are stopped. So when we looked in our cohort, more than 40% of patients who developed inflammatory arthritis as an immune-related adverse event had persistent symptoms at 6 months after stopping the immune checkpoint inhibitor. And the most important risk factors for developing persistent arthritis was being on a longer duration of therapy with immune checkpoint inhibition and being treated with combination ICI therapy. I don't want to go through this table in great detail, but I just wanted to illustrate how complicated decision-making can be in these patients in terms of choice of therapeutic agent that we can use to treat rheumatic immune-related adverse events. And so some of the things that we have to factor in is what is the likelihood that a given drug will be efficacious? How long does it actually take for that drug to exert an effect? What is its potential effect on cancer responses? And could we inadvertently have a negative impact upon the cancer? Is there a potential for overlapping side effects with immune checkpoint inhibitor therapy? And what's known to date about the use of these drugs for immune-related adverse events? So I just wanted to highlight a couple of these. Methotrexate is a DMARD that we use commonly to treat these immune-related adverse events, and it has a moderate likelihood of efficacy. The time to onset is 2 months on average. So we have to think about this, especially in these patients where we're starting to see rapid development of erosions. And thus far, there isn't data to suggest that there is a significant negative impact on cancer responses. We are increasingly using TNF inhibitors in these patients as well, which have a high likelihood of efficacy and a more rapid time to onset. And there is a theoretical risk about the effect on cancer responses, but thus far in our data to date, we haven't seen that bear out. And I mentioned to you that the MD Anderson Cancer Center Rheumatology Group has used anti-IL-6 therapy with tocilizumab. And again, this can have a fairly quick time to onset and high potential for efficacy. In our experience, we have not been using this as much, in part because our oncology colleagues have been concerned about using anti-IL-6 therapy because of this potential for overlapping side effects, because we can see immune checkpoint inhibitor induced colitis, and we know that with anti-IL-6 therapy, there can be a risk for GI complications, including perforation. So just to give you a sense of the complexity of decision-making that's involved in these patients who have cancer. This really has a significant impact on the quality of life for patients who develop immune checkpoint inhibitor-induced inflammatory arthritis. We had performed a qualitative study to understand the experience of patients who develop this. And you can understand how complicated this may be because a patient has a cancer diagnosis, they can be debilitated by inflammatory arthritis, and both of these can affect treatment decisions for the other. Patients identified that there was a lack of awareness about inflammatory arthritis as a potential immune-related adverse event among their oncology providers, and that this was resulting in a diagnostic delay. And they were also concerned that there was a lack of social support when it came to the inflammatory arthritis, that people in their communities and their families can understand cancer and its potential impact, but really didn't understand the inflammatory arthritis. Many of these patients expressed a fear of the cancer returning and progressing, and the impact that this would have on the decision to continue immune checkpoint inhibitor therapy. And just to give you a sense of this a little bit more, I have a few quotes that patients had said just to give you a sense of the patient experience. So this was a patient with stage 4 melanoma, and she described that she was given 1 to 3 months. And she said, that takes the wind out of you, I tell you that. But getting to the arthritis point part, there came a point where I went out on disability, not because of the cancer itself, but because of the side effects from the cancer treatment. Another patient described that the arthritis continues to be a much bigger problem than other side effects like thyroiditis and colitis, as far as the level in which it affected my body, the length of time that I'm dealing with it, and the effect that it's had on my quality of life, by leaps and bounds a bigger deal than the thyroid or colitis issues. Another patient said, the arthritis knocked me back a lot harder than honestly the cancer diagnosis because I could not move. I was on the sofa or in bed for days without knowing why or if this was ever going to get any better, and it was terrifying. And this last quote I thought was really telling. This patient said, I would be hard pressed to say that I would have continued as long as I did in the trial. This is referring to the immunotherapy trial, if I had known about the side effects. The other option, of course, is to be dead, but at some point it becomes a toss-up. So just to give you a sense of the challenges that these patients are feeling and the intensity of the arthritis that can develop. So before I leave the topic of ICI-induced inflammatory arthritis, I just wanted to compare and contrast this with some of our traditional rheumatic diseases, because I think there are some interesting similarities and differences. So when we think about inflammatory arthritis as a rheumatic IRAE and compare this to rheumatoid arthritis, some notable similarities are that you can see polyarthritis, development of erosions, and involvement of small joints. But important differences, again, are that these patients are mostly negative for rheumatoid factor and anti-CCP, and we don't see the same female predominance. And when contrasting to spondyloarthritis, again, we can see enthesitis, enthesophytes, dactylitis, oligoarthritis with involvement of large lower extremity joints and development of reactive arthritis. But these patients are largely negative for HLA-B27. It's rare to see concomitant psoriasis, and inflammatory axial disease is rare. So moving on to the second case, this is a 61-year-old man who had metastatic lung cancer and was started on anti-PD-1 therapy. And a month and a half after starting therapy, he developed dry mouth with difficulty swallowing, had burning of his tongue, and decreased taste. He was given a course of fluconazole from his oncology provider, and his burning tongue got better, but the dry mouth persisted. He denied dry eyes, he did not have a foreign body sensation, and there was no evidence of parotid swelling. On exam, he had severe xerostomia, and his lab showed a moderately positive ANA at a titer of 1 to 320. He had a slightly elevated rheumatoid factor, and his Rho and La antibodies were negative. And he was managed with topical oral agents and then cevimeline. So in terms of the presentation of checkpoint inhibitor-induced Sikka syndrome, patients can develop dry mouth and dry eyes, and the onset can be acute and quite severe. The median time to develop Sikka syndrome has been described as 70 days from starting immune checkpoint inhibitor therapy in one series. And in general, it seems like the dry mouth symptoms are much more pronounced than the ocular symptoms. So in 2 case series, it was reported that 14 out of 20 patients did not have ocular symptoms, and in another 4 out of 5 did not have ocular symptoms. And parotitis is very rarely reported. It's important to note that mucositis can also develop from immune checkpoint inhibitor therapy. So when patients with ICI-induced Sikka syndrome have been studied, they've been demonstrated to have decreased saliva production when looking at whole unstimulated salivary flow. Schirmer's testing has also been done to evaluate for ocular dryness. And again, this is less common, but has been reported as being positive in 25% of an NIH cohort of patients and 38% in a European group. And most of these patients are seronegative for Rho and La antibodies. And in one study, they did minor salivary gland biopsy. And I thought this was really interesting to compare and contrast the array of histologic findings that can be seen with immune checkpoint inhibitor-induced disease, and to look at that relative to Sjogren's syndrome. So in panel B, I'm showing you a picture of a salivary gland from a patient who developed mild immune checkpoint inhibitor-induced focal silent adenitis. But in C, this is a patient who developed a very severe disease. And you'll see that in contrast to Sjogren's syndrome, there was not CD20 expression in the salivary gland, but there was marked upregulation of PD1 and PDL1. And this patient had significant destruction in the salivary gland, showing that the acini were destroyed. So it's interesting to look at the variability in histology that can develop in patients with checkpoint inhibitor-induced Sikka syndrome, and also to look at the differences relative to primary Sjogren's syndrome, because this may explain differences that need to be considered in treatment approaches. So in terms of treatment, really the mainstay of treatment is saliva substitutes and use of sialagogues, and close partnership with our dental and ophthalmology colleagues. Patients may require the use of artificial tears and punctal plugs. But in contrast to Sjogren's syndrome, these patients may require the use of corticosteroids. So prednisone 20 to 40 milligrams a day has been used for patients who have grade 2 or higher symptoms. And so that means patients who either need to drink copious fluids to chew or swallow, or those who have to restrict their diet to purees or soft moist foods, or those who actually need to use oral lubricants. And again, this ties into the histologic findings that we can see suggesting that these patients may require immunosuppression. So if we compare and contrast again, ICI-induced Sikka syndrome to Sjogren's syndrome, they are similar in that dry mouth can respond to sialagogues and can be severe and associate with candidal overgrowth. But notable differences are the seronegativity, the lack of parotitis, that the pathology is different. There are not as many focal centers, and it can be much more destructive with use of immune checkpoint inhibitors. These patients may respond to steroids, and they disproportionately have more dry mouth than dry eyes. So the third case is a 61-year-old woman who had a stage 3B poorly differentiated carcinoma. And she was in a clinical trial with an anti-PD-L1 agent. And a month after starting therapy, she developed pneumonitis. She was treated with steroids over a 3-month period. And after her steroids were stopped, she described worsening pain in her shoulders, hips, and buttocks, and morning stiffness in her hips and shoulders. She denied any temporal headache, scalp tenderness, jaw claudication, or visual changes. And on exam, she had no evidence of joint swelling. She was tender over both shoulders and the bilateral greater trochanteric areas. She had markedly elevated inflammatory markers, and she was diagnosed with polymyalgia rheumatica. This patient was started on prednisone 15 milligrams a day with immediate improvement, and she was tapered off once she was started on chemotherapy. So in terms of ICI-induced polymyalgia rheumatica, these patients again can have shoulder and hip girdle pain and stiffness and morning stiffness, and can have peripheral arthritis as well, which is somewhat different than typical PMR. Patients can also develop giant cell arteritis with or without PMR symptoms, and with classical symptoms that we think about for patients with GCA, with temporal headache, jaw claudication, and vision loss. And this has been seen across all classes of agents. In terms of diagnosis and treatment, so in patients with ICI-induced PMR, most of these patients do have elevated inflammatory markers, but not all. And in cases of GCA, inflammatory markers have been markedly elevated in published reports. Ultrasound studies have been done looking at patients with checkpoint inhibitor-induced PMR, and there's been evidence of subdeltoid bursitis, biceps tenosynovitis, glenohumeral synovitis, hip synovitis, and trochanteric bursitis. It's important to note that if a patient presents with headache after an immune checkpoint inhibitor, it's really important that we get a temporal artery biopsy, just as we would for other patients when we're evaluating for GCA, just because there are multiple types of steroid responsive headaches. And really, the biopsy is critical to determine how long a patient may require ongoing corticosteroid therapy. And steroids really are the mainstay of therapy here. So checkpoint inhibitor-induced GCA is treated much as we treat traditional GCA with fairly high doses of corticosteroids, including pulse solumedrol therapy if there's concern for vision compromise. But interestingly, patients who have developed immune checkpoint inhibitor-induced PMR often require higher doses of steroids than what we use for traditional PMR. So it's been reported that patients have required doses up to 60 milligrams a day of prednisone, and even that there can be refractory cases that have required treatment with tocilizumab. So again, if we compare ICI-induced polymyalgia-like syndrome to traditional PMR, we can see similar ultrasound findings, but inflammatory markers are not always increased, and these patients may require more aggressive therapy than we would use for traditional PMR. And when comparing GCA in those who have had checkpoint inhibitor exposure to traditional GCA, we can see similar temporal artery biopsy findings, a similar age distribution and high inflammatory markers, but thus far it has not been reported that there is associated aortitis or other large vessel vasculitis in patients who have been exposed to checkpoint inhibitor therapy. The last case I have is a 61-year-old woman with ovarian cancer who developed proximal muscle weakness a month after starting anti-PD-L1 therapy. She had no rash or other symptoms. Her CK was elevated in the 1400s, and she had a high titer ANA in a nucleolar and homogeneous pattern. Her immune checkpoint inhibitor was stopped, and she was started on prednisone 1 milligram per kilogram per day. Her myositis specific and associated antibodies were negative. And by the time she had her EMG and muscle MRI testing, these were not terribly revealing. So her EMG was normal and her MRI showed muscular atrophy and fatty replacement. So in this instance, with treatment and holding the immune checkpoint inhibitor, her CK normalized and her strength improved. So when we think about checkpoint inhibitor induced disease, we're really seeing two different phenotypes here. Predominantly polymyositis-like disease, where patients can have proximal muscle weakness, which predominates, although there can be distal muscle weakness. In many instances, diaphragmatic weakness has been noted, and dysphagia can be seen as well. And importantly, this has been described in overlap with myasthenia gravis and myocarditis. So it's important for us to look for these overlapping features. Dermatomyositis has been more rarely reported, with classic rashes that we expect to see with DM, including Gauthrin's papules and nail-fold capillary abnormalities, but PM-like disease is more common. In terms of diagnosis, again, muscle enzymes are typically elevated, and you can see the range can be quite high, ranging from 1,000 to 10,000. There have also been reports of transient CK elevations with minimal symptoms. And classically, patients do have evidence of an irritable myopathy on EMG and muscle and fascial inflammation on MRI. And on muscle biopsy, it's been shown that these patients can have endomysial lymphocytic infiltration and necrotizing myopathy in a subset of patients. So the mainstay of treatment here is really corticosteroids, and you can see the range of dosing that's been reported in the literature has been highly variable. There has been the requirement for IVIG and plasma exchange in severe cases that have been published in the literature. And in all instances, it's been described that immune checkpoint inhibitors are held or discontinued. So again, when we compare ICI-induced myositis to dermatomyositis, polymyositis, and the immune-mediated necrotizing myopathies, we can see some similarities in terms of the level of CK, the presence of irritable myopathy, and some of the histopathologic findings. But again, classic DM rashes are rare. It's been reported that IVIG may be less effective. We don't typically see myositis autoantibodies. And then we can see this overlap with myocarditis and myasthenia gravis. I won't be able to go into all of these today, but again, to just report that there are increasingly more and more cases that are published in the literature describing other rheumatic immune-related adverse events, including psoriasis and psoriatic arthritis, significant vascular manifestations with brain nodes and digital ischemia, accelerated osteoporosis, GCA, lupus nephritis, et cetera. So one of the challenges for us as rheumatologists treating patients who are developing these immune-related adverse events is we're a little nervous about using immunosuppressive therapy in these patients. And in part, it's because of the concern of, are we going to attenuate the anti-tumor effect of the immune checkpoint inhibitor therapy? And what is the potential impact that this could have for a patient's cancer? And there's also concern about the potential overlap in terms of side effects between the disease-modifying drugs we use and the cancer therapies that a patient is receiving. So in terms of safety of immunosuppression for immune-related adverse events, we really don't have great data. So I'll summarize this by saying the data is mixed and largely limited to short-term exposure. So when they've looked at use of steroids and short-term TNF inhibitors for any type of immune-related adverse event in a melanoma study, they didn't see any adverse effects on the melanoma. There were 2 studies that looked at multiple tumor types in patients who were treated with anti-PD-1 therapy. And again, when patients developed immune-related adverse events and required steroids, it did not negatively influence survival or response. But there was one study looking at patients who developed hypophysitis when they were receiving ipilimumab for melanoma, and those who got high doses of steroids did have worse survival. And similarly, there's been a question about what about baseline immunosuppression in these patients? So in one study, patients who were on baseline corticosteroids receiving more than 10 milligrams of prednisone a day had worse responses when it came to their non-small cell lung cancers. But it could be that having an immune-related adverse event is actually a good thing. So in multiple studies in melanoma and in non-small cell lung cancer, patients who developed IRAEs had better prognoses and tumor responses. And in one study looking at nivolumab in melanoma, the response rate was actually higher in patients who had even more severe IRAEs. So they described an 80% response rate of tumor regression in those who had a grade 3 or higher immune-related adverse event. Jury is still out in this front, especially because those who have higher grade events and need steroids, especially high doses of steroids, we don't know what the impacts are, but thus far it suggests that having an immune-related adverse event could be beneficial. So for the last part of this, I just wanted to talk about pre-existing autoimmunity and whether or not patients who have pre-existing autoimmunity can receive immune checkpoint inhibitors. So this is a question that comes up for us as rheumatologists, as we're seeing our patients with rheumatoid arthritis and scleroderma and myositis developing cancer. And it's a bit of a challenge because patients with pre-existing autoimmune disease were excluded from all of the initial clinical trials looking at immune checkpoint inhibitor therapy. So the data that we have is only from retrospective series and systematic reviews and one national study from France. So I've just picked a couple of these to give you a sense of the flavor of the literature. So in this first systematic literature review, they included case reports and series and observational studies with a wide array of autoimmune diseases. And these are not just rheumatologic diseases. So this included patients who had autoimmune thyroid disease or IBD. In total, there were 123 patients, and of these, 75% had an exacerbation of their pre-existing autoimmune disease. And there were an equal number of exacerbations in those who had active versus inactive autoimmune disease at the time that they started their immune checkpoint inhibitor. 25% of these patients developed a de novo immune-related adverse event, and 17% had to discontinue their immune checkpoint inhibitor therapy due to adverse events. In this study, 27% of patients were receiving immunosuppressive therapy when they started their immune checkpoint inhibitor. And there were an equal number of exacerbations in those who were and were not on immunosuppression, but potentially there was a lower rate of de novo IRAEs in those who were immunosuppressed. And there were some differences by type of immune checkpoint inhibitors. So those who got anti-PD-1 or PD-L1 therapy had a higher rate of disease exacerbations, whereas those who received anti-CTLA-4 therapy had a higher rate of de novo immune-related adverse events. And just to give you a flavor of this from a rheumatologic perspective, for the patients who had rheumatoid arthritis, 35% had a flare of their arthritis, 25% had a de novo IRAE, and 15% had both. There was another systematic literature review that was just published this year and included over 500 patients, again, with a wide array of autoimmune diseases and a wide array of tumor types. And 68% of these patients had some kind of immunotoxic effect. They defined that 44% had a flare of their underlying disease and 18% had to discontinue their immune checkpoint inhibitor therapy. And they didn't see any difference in efficacy when these patients were on immunosuppression. And the last study I wanted to highlight was the study from France, looking at 3 different centers where they had 112 patients with pre-existing autoimmune disease, 22% of whom were on immunosuppression when they started their immune checkpoint inhibitor therapy. They saw a much higher rate of immunotoxicity. So 47% of these patients had disease flares, 42% developed IRAEs, and 21% had to permanently discontinue the immune checkpoint inhibitor therapy. Interestingly, most of these patients who had disease flares of their underlying autoimmune disease had flares that were characteristic of what they had experienced in the past. But for patients who had PMR, they often developed new onset polyarthritis with their PMR. And median progression-free survival was shorter in patients who were on immunosuppressive therapy. And that's just shown here, where this line is reflecting patients who were not on immunosuppression at baseline compared to those who were. And we can see that progression-free survival was worse in those who were immunosuppressed at baseline. And there was a trend suggesting a potential difference in overall survival, but this was not statistically significant. They also tried to look at strength of immunosuppression to see if there were differences by agents, but in this sample size, there were no clear differences that were observed. So I think this illustrates that there's a lot we don't know. And in an attempt to better characterize these events, these rheumatic immune-related adverse events, we've established a multi-center consortium known as the RADIOS Consortium so that we can collect these events across sites and better characterize them and also study the underlying biology of the disease. Because for us as rheumatologists, this actually provides a unique opportunity to study the development of an autoimmune phenotype where we actually know the inciting trigger. So when we think about unanswered questions, there are many. So some of them include, are there clinical risk factors that are prognostic for the development of rheumatic IRAEs when a patient is starting an immune checkpoint inhibitor therapy? So for instance, if we know that a certain factor is going to predispose somebody to developing inflammatory arthritis, would there be utility to preemptively putting that patient on an agent like hydroxychloroquine? How should we actually treat these immune-related adverse events when they develop? Should we be treating really aggressively with high-dose steroids and then taper, or should we be using a low-dose regimen with step-up therapy? And again, this is really an important question as we're seeing these patients who can have rapid development of erosive disease. How early should we be using conventional synthetic DMARDs and biologic agents in these treatments? And do all of these rheumatic IRAEs have the possibility of becoming chronic processes, or is this something unique to inflammatory arthritis? And on the translational side, again, we really think this could be an interesting wedge to study the relationship between cancer and autoimmunity and to study how our traditional rheumatic diseases are developing. So some important questions here are there pre-existing autoreactive T cells in these patients or autoantibodies? Could those be relevant to disease pathogenesis? Or are we seeing the development of these self-targeted immune responses after exposure to the immune checkpoint inhibitor? And in either case, what antigens are these cells or antibodies recognizing? Is there some kind of genetic predisposition for the development of IRAEs? And what other effector pathways are most involved and targetable? So with that, I just want to summarize that arthritis and Sikka syndrome are the main rheumatic IRAEs that we see with immune checkpoint inhibitors. But again, there's a wide array of other phenotypes that can be seen. We think that there are distinct patterns of inflammatory arthritis and other IRAEs that are emerging depending on the type of cancer therapy that a patient is receiving, and that the incidence of these events is likely to grow as the use of immune checkpoint inhibitors grows. This requires close partnership between rheumatologists, oncologists, and other subspecialists to take care of these patients, and there's a lot for us to learn. So thank you again for the kind invitation to present to your group. And I just wanted to acknowledge that some of the work from our group that was presented is the work of many people here. So thank you.
Thank you so much. Wonderful talk. I'm probably a bit of a novice here, but it was a fascinating talk and really interesting. Dr. Shah, do you have any immediate reflections or questions that we can help facilitate?
I think it's an excellent talk, Ami, and especially when we are kind of seeing these new agents being used for cancer treatment, and a lot of consults are coming our way. So I think it's important to recognize these cases and kind of timely treatment. One question I have is is there anything in the literature or in your experience to maybe do it for patients who have existing rheumatologic diseases, maybe to keep them on low dose prednisone to help? Because I have a couple of cases which I have come across where patients are kind of stable, but oncologists have asked me that would it be beneficial to just put them on 5 milligram of prednisone if we think that this may flare them?
Yeah, it's a great question, and one for which we don't have much data. So I will say that, when they've looked at this, for instance, in the non-small cell lung cancer literature, patients who are on steroids at baseline may have had impaired anti-tumor immune responses compared to those who weren't. But in terms of what is the right cut point, could somebody tolerate 5 milligrams of prednisone as a preventative, but still maintain a robust anti-tumor immune response? I don't think we have the data yet to support that. In most instances, we're really trying to make an assessment for our patients with pre-existing rheumatic diseases. What is their level of disease activity? So if somebody is effectively quiescent, our clinical practice right now is to let them proceed with therapy and follow very closely along with the oncology provider to monitor for disease flares and de novo immune-related adverse events without using preemptive therapy. But again, for instance, a patient with inflammatory arthritis, if you had them on hydroxychloroquine, could that be an effective strategy just to prevent disease flares? It's a really important question.
Okay, thank you.
Yeah.
I think I'm gonna maybe look at some of the questions from the chat and present it to you. So
Sure. Dr. Schwartz asked, can you imagine a way that the use of a checkpoint inhibitor could be better targeted to the cancer target than against the autoantibodies or autoantigens?
Yeah, so I mean, here we're really talking about kind of non-specific general T cell activation, right? And so it is definitely of great interest if we could better target immunotherapeutic agents in a more effective way. I think there's so much work that's being done in the oncology space to define important targets to go after. But in terms of how immune checkpoint inhibitors specifically could be targeted to distinct cancer antigens, I'm not aware of the literature on that at this point in time. Thank you. It's an important question.
Could I ask a question about, I'm a pulmonologist by training, so my question is going to relate to smoking and the use of checkpoint inhibitors, and whether smoking, given its role in things like rheumatoid arthritis, are you seeing any signals from ongoing smokers in terms of their susceptibility to arthritis from immune checkpoint inhibitors?
That's a great question. So in our limited samples to date, we haven't seen smoking as a risk factor for the development of checkpoint inhibitor-induced inflammatory arthritis. But you raise an interesting question about what is somebody's predisposition to develop an immune-related adverse event. We have done some small pilot studies showing that patients who have genetic predisposition to develop rheumatoid arthritis, so for instance, the presence of shared epitope alleles, that these patients are much more likely to develop checkpoint inhibitor-induced inflammatory arthritis than patients who don't have those genetic features. So there likely are characteristics and a set of characteristics that are really important and can predispose for people to develop distinctive phenotypes. See another question that came through. Does persistence after stopping a checkpoint inhibitor correlate with either more severe cases or multi-organ adverse events? That's a great question. So definitely we are seeing that those who have persistent inflammatory arthritis are those who have more severe and aggressive disease. These are patients who are requiring longer term use of TNF inhibitor therapy. I don't think we've observed a pattern in terms of multi-organ adverse events other than the fact that patients can develop multiple events in series. And often the patients who are persisting are those who have been on combination immunotherapy. And so they are predisposed to developing multiple IRAEs. But in terms of having persistent, severe other multi-organ events, I don't think we've seen evidence of that.
I think we have time for one last question, and then we will, this is from Beth Rubenstein. Is it possible, given the underlying predisposition, potentially a shared epitope you observed, suggests that we are uncovering disease early with the initiation of the checkpoint inhibitors?
Yeah, I think that's a great question, and I think it is certainly possible. So here I gave the example of a genetic predisposition, but just to give you another one that was described by one of my colleagues in Japan, he had seen a patient with cancer who was found to have anti-TIF1 gamma antibodies, which we as rheumatologists know can associate with cancer-associated myositis. And the patient did not have clinical features of myositis, but when exposed to the checkpoint inhibitor, developed classic dermatomyositis. So I think you're right that we may be uncovering patients who at least have this latent potential to develop autoimmune disease by administering these agents. Thank you, that's a great question.
Thank you so much, Dr. Shah. We appreciate your time and being with us here for a whole hour and taking a couple questions afterwards. Really fascinating work. So thank you, Dr. Amit Shah from Hopkins, and thank you, Dr. Nihal Shah from our Division of Rheumatology. Just a quick housekeeping item. We'll put the code up in the new innovations tab, but Dr. Shah, Dr. Syme, anything you would like to add?
I very much enjoyed it. Really enjoyed the case presentations and the link to the basic immunology. Wonderful translational grand rounds. Thank you.
Thank you very much.
Thank you. It was a great talk.
Thanks.
Thank you so much.
Have a good day.